All right, so we're going to get started tonight. Welcome to the National Fellows Online Lecture Series. This is a lecture series sponsored by the Online Education Subcommittee, Education Committee, and the Fellowship Committee. I want to remind you that next week we do not have anything. It's Thanksgiving week, but the next lecture we will have will be on December 3rd. It's on pediatric spine, and we'll have Dr. Michael Beasley speaking to us with Dr. Emily Sweeney being our moderator. Tonight, we have chronic exertional compartment syndrome and exertional leg pain. It's we are being spoken to by Dr. Landon Mueller. I am Laura Goldberg, I'm moderating. And if you have any questions or anything, you can go ahead and put them in the chat. The goal of tonight is that we're really supposed to supplement your own program's educational content. And our hope is to really give you some access to educational content experiences with established AMSSM members. Sometimes we'll have invited guests that are specialists in the area. And the overall goal is to assist in your CAQ exam prep. We do want you to know that we want to know what you guys want to hear. So we want to make sure that we get your input. There is a section on the website that you can click onto and put in information, topic suggestions, speaker suggestions, and whatnot. There's also a QR code that you can scan here, and it'll take you directly to that page. Remember, the primary goal of the lecture series is to assist in the CAQ preparation. I'm going to leave that up while I introduce our speaker, Dr. Landon Mueller. He is Assistant Professor of Clinical Emergency Medicine at Georgetown University School of Medicine and an attending physician in the Emergency Medicine and Sports Medicine with MedStar Health. He serves as the Program Director for the MedStar Health Georgetown University Primary Care Sports Medicine Fellowship. He's also the Special Activities Director for the Emergency Medicine Residency. He's team physician for Georgetown University, team physician for the Old Glory Rugby Team of DC, and an airway emergency physician for the Washington Capitals. He completed his sports medicine fellowship at his current program and his emergency medicine residency at Virginia Commonwealth University in Richmond, VA. He clearly has a lot of sports experience and is here today to talk to us about exertional leg pain.
Awesome. Well, thank you for that introduction. So let's talk about exertional leg pain and CECS. I'm sure, hopefully, we're all familiar with the term chronic exertional compartment syndrome, but a lot of the talk, I will shorten it to CECS just because it's easier to say. So just for everyone to keep in mind. And I'll also have a big shout out to my mentor and our former speaker for the AMSSM fellow lectures, Dr. Corey Hudson, who I got a lot of her slides and ideas from for this talk. So thank you to her. Let's start with a patient. We have a patient who comes into your clinic who has been complaining of bilateral lower extremity leg pain for the last couple of months. If that patient looks very young and looks like my 10-month-old son, maybe trust your instincts on that. But let's say your patient's name is Liam, and he is complaining of bilateral lower extremity leg pain, which happens anytime he goes to crawl really fast, i.e. run, anytime he tries to run. He starts, he can go through his workout, and at first he feels okay, but then he starts to have some ongoing cramping sensation. The pain starts to get worse as he continues throughout his exercise until eventually it gets very painful, and he even starts to have a little bit of numbness going down the front of his legs. He swears that when he stops his workout that his legs look like twice the size, that they're swollen. And so he comes to you for evaluation, and that is what we are going to talk about today. So what is exertional leg pain?
Landon,
so we define, yes.
Are you sharing your screen?
Yes.
Can other people see it?
Yes.
Perfect. Sorry, I couldn't see it. I don't know why I wasn't up. I didn't mean to interrupt. Go ahead.
Okay. All right. Long story good. So The definition of exertional leg pain is any pain that is distal to the knee and proximal to the ankle joint. Typically begins with exertion, running, playing with sport, and if it becomes severe enough, and depending on the diagnosis, may progress to pain with just daily living. It's most often seen in runners, but can occur in any type of field sport athlete, anything that involves running. And I've even seen some exertional leg pain in like weightlifters with repetitive squatting and things like that. This is one of the key slides to remember, which is our differential diagnosis for exertional leg pain. And we break things down into four big buckets. We have our bony causes, our vascular causes, muscular, which includes CECS, and our neural causes. And we'll go through all these four big buckets and focus a lot, of course, on CECS, like we're talking about. So let's go into the bony bucket. So these are things, I'm not going to spend too much time on this bucket because I think as sports medicine clinicians, we actually see this pretty frequently. And this ends up still being, I think, the biggest bucket that most of our patients will fall under. So we'll start with on our differential shin splints, just general medial tibial stress syndrome, which can affect up to 20% of runners. We don't fully understand the etiology. Typically, the pain occurs in the middle or distal third of the tibia, primarily on that medial border. You do not have any pain at rest, so with just true shin splints, people should not really have pain with rest or with ambulation, but it typically begins with exercise and then stops with rest. You can have navicular drop in pronation. That's also been associated with increased BMI. So this is very common. I'm not going to spend too much time on that. Same with stress injury. And what I like to think of bone stress injury occurring on a spectrum. So we have anything from a stress reaction all the way to a true fracture with a stress fracture. The true incidence is unclear because a lot of times our runners, those who are training for marathons, they may, have some form of bone stress injury that they're just pushing through. And it tends to be, I think, if you would MRI a lot of these people, they would have some form of a bone stress injury, even during, a normal training block. But it occurs on a spectrum. It's an insidious onset. You need to get a good history about their training history. Did they ramp up their volume? Are they in new shoes? Are they trying a new training program? Are they having decreased recovery? That could be affecting. Most of the stress injury is going to occur in the diaphysis, but can occur anywhere throughout the bone. Risk factors include things like RED-S, shoes, prolonged shoe wear use without getting new shoes. And the big one that I tend to see, which I really focus on, is a rapid increase in training. With a stress injury, they're oftentimes going to have focal tenderness as opposed to shin splints, which are going to have more diffuse pain. Our diagnosis for this is primarily going to be MRI. Bone scan is still useful, although has largely been supplanted by MRI. And then X-rays we're going to start with, but the sensitivity and specificity for stress fractures is not significant enough. So MRI is really our go-to test for this. In our vascular bucket, there's a couple of big things that we don't see as much in our athletes. So true peripheral arterial disease, it's more common in our older patients. You may see that in a older, weekend warrior athlete, something to keep in mind. We also see peripheral venous disease with venous stasis, discoloration, wounds, things like that. Again, that's fairly obvious. We're not going to see that as much in our athletic population. The big kind of vascular bucket that I tend to think of with exertional leg pain is popliteal artery entrapment syndrome. And this is essentially where we're getting claudication of the popliteal artery with exercise. It occurs in about 40% of the time in the bilateral legs, and it's thought to be from mechanical compression of that popliteal vessel. There are several subtypes. We have 5 anatomic types, which we'll go over, and then you have the functional type, which doesn't have anything necessarily anatomically wrong with it, but thought to be a functional compression of the vessel. And then we diagnose this with MRA, angiography, and ultrasound ABIs pre and post exercise, which we'll go over. So there are thought to be 5 anatomical variants. Now this diagram actually shows on the left is actually normal. So our normal anatomy is the medial head of the gastroc is medial to the popliteal artery. So we have our medial head, our popliteal vessels, and then the lateral head of the gastroc. A type 1 anatomical abnormality is where the popliteal artery actually courses medial to the medial head of the gastroc and gets compressed. A type 2, which is, as we'll show, the most common anatomical variant, is where the medial head of the gastroc is anatomically lateral to the popliteal artery. So it's just a little variant. And so then that popliteal artery courses underneath and gets compressed. A type 3 variant is where there is an extra kind of fibrous band. The gastroc is normally positioned, but there's an extra fibrous band that then compresses the popliteal artery. And then type 4 is where the popliteal artery gets entrapped by the popliteus muscle. And then type number 5, which is not included on this diagram, is actually where the popliteal vein gets entrapped, but that is far less common. So these are the four main anatomic variants. And of these, the one to remember, the most common, is that the medial gastroc is more lateral than it should be. And so that popliteal artery is being trapped by the medial head of the gastroc. So remember that for a future CAQ question. So when we look at the patients who actually get popliteal artery entrapment syndrome, about 74% of the time, it's actually a functional cause, which means when you get an MRI of these patients, there's actually no anatomical variant. And it's just thought that with exercise, that popliteal artery is getting trapped, primarily thought to be from a hypertrophied gastroc. So even if the gastroc is normal in position, if the gastroc is hypertrophied, then it may still compress that popliteal artery as it courses through. And so that is the basis of functional popliteal artery entrapment syndrome. The functional variation most often occurs in athletic females between ages 20 and 29, whereas the anatomical variants are more often in men, kind of around the same age. Symptoms are claudication, achy cramp-like pain after exercise, and then they may also experience paresthesias in the lower leg, foot swelling, pallor, cramping, blanching, and cold feet. So obviously, if we see like pallor and cold feet and blanching, that's going to be a big tell that's different from our other big buckets of exertional leg pain, but it's not super reliable as those are not going to be seen on every patient. The one kind of unique physical exam maneuver that we're going to do to evaluate for these patients is we're going to palpate their pedal pulse, but you're going to do that with their knee in full extension. So you're basically trying to compress that popliteal artery as much as possible, and then you're going to add in some ankle dorsiflexion and some passive ankle dorsiflexion and active plantar flexion. And you're going to measure the pedal pulse with both those movements, because the idea is that you're trying to basically activate that gastroc and see if that activation compresses the space even further and then reduces your pulse. So if you're palpating the pedal pulse and you feel a decrease when the patient does that maneuver, then that is highly suggestive of popliteal artery entrapment syndrome. And then you're also going to look for hypertrophy of the gastroc. If this is already on your differential and then you see someone has massive gastroc, then you might want to consider that they have a functional popliteal artery entrapment syndrome. This is just a little diagram, a little table going over those different types that we just went over, and the treatment, specifically the surgical treatment available. My key takeaway from this slide is that know that there are surgical options for all these anatomical variations, which is basically a myotomy and rerouting of the popliteal artery. But again, the big takeaway is about 50% of our variants occur in that type 2, where that medial head is attached in a more lateral position. And then this is a theoretical algorithm for how we can consider diagnosing and treating popliteal artery entrapment syndrome. So let's go through a few key findings here. So the first thing, if we're considering this diagnosis, then the first kind of unique test that we're actually going to get is an ABI, or an ankle brachial index, which allows us to get an idea if there is diminished blood flow relative to the upper extremities with that ABI. If we have a normal ultrasound, then we essentially say it's unlikely to be popliteal artery entrapment syndrome, and we need to consider something from one of the other three buckets. But if you do have abnormal ABIs, then the next thought is to get an MR angiography study or a CT angiography study. And these are actually going to be done in a dynamic manner with the patient plantar flexing, because again, you want to see when they're undergoing this active movement, is that when you actually have the popliteal compression. So if the popliteal vessels demonstrate dynamic compression with the patient plantar flexing during those imaging studies, then this author of this paper that I quoted actually recommends a trial of Botox. And the idea with Botox is that we are putting that Botox into that medial head of the gastroc, and we're trying to paralyze it to some degree and see if that reduces our symptoms. So Botox is it's still a little thought to be experimental, but Botox is recommended as a first trial. And if it works, great, you continue doing Botox. If not, then you go to one of those surgical interventions. And then, of course, if the popliteal vessels appear stenotic or occluded even at rest, then that's a more emergent vascular surgery consult. So kind of again, the algorithm is we're thinking about this, we're getting ABIs. If those are abnormal, then we're going to get more advanced imaging with dynamic MR angiography is usually my go-to, especially to reduce radiation. There's another diagnosis under the vascular um, bundle called iliac endofibrosis. This is most commonly seen in cyclists, which is where the iliac artery basically enlarges due from the recurrent flexion of the hip and the iliac artery. If you think about every time a cyclist brings their hip up in the cycling motion, that can potentially kink that iliac artery and cause vascular compromise. So this is more of, you'll see this on the CAQ, thinking about, a cyclist coming in with popliteal artery type symptoms with claudication, gets worse, they may have pallor in the foot. This is something to think about. And it's primarily cessation of the sport, so they have to stop cycling and we stop kinking the iliac artery, or you can have surgical intervention. And then we get to the bucket of muscular and specifically CECs. So this bucket will contain about 14 to 27% of athletes with otherwise undiagnosed exertional leg pain. 95% of the time, exertional leg pain is occurring in the lower leg. You can get it in other compartments, but that's pretty rare. We don't really understand the pathophysiology and we don't really understand where the pain generator is coming from. We think that there may be thickened fascia, there may be reduced microcapillary capacity, maybe there's an element of venous congestion, maybe there's increased interstitial volume, but we just don't really know why it happens. We just know that it does. And of the 4 compartments of the lower extremity, it's by far the most common in the anterior compartment, followed by the deep posterior compartment. And then less frequently, number 3 is the lateral compartment, and then superficial posterior is the least involved in the smallest amount. So most of the time, we're going to be seeing this in the anterior compartment, and then either deep or lateral compartments. Let's just kind of review our anatomy. I think this is a really helpful slide to review our 4 different compartments. So again, our anterior compartment, that's the one that's most often involved. There's some key structures to remember. And these, play a role in our CAQ questions. So our big muscle groups in the anterior compartment are that tibialis anterior and the extensor digitorum longus and extensor hallucis longus. So if you take out that anterior compartment, that's where you're going to get a foot drop because you're losing that ankle dorsiflexion. The innervation of that compartment is your deep peroneal nerve. Then we have our lateral compartment where we have our peroneus longus and brevis muscles. That is innervated by the superficial peroneal nerve. We also have our deep posterior compartment with some of our toe flexors, our flexor digitorum longus, tibialis posterior, that's innervated primarily by the tibial nerve, and then we have our superficial posterior compartment, which is innervated by our sural nerve that has our soleus and our gastroc. So keep these 4 compartments in mind, especially that anterior compartment, because again, that's the most common one that we see. And then finally, our last bucket of diagnosis is neurogenic or neural mediated. So this can be a couple of different things. We have radiculopathy, primarily L4, L5, S1. I'm not going to touch much more upon that. We see radiculopathy, radicular pain, and lots of patients with low back pain, but always something to consider even in our runners. Then we have peripheral nerve entrapment, and that's more, I think, relevant. It's one of the things that I think more in these types of patients. And you can have nerve entrapments at the saphenous nerve, which is a branch off the femoral nerve. That's a lot less common, but that can cause some of your medial pain. Then you can have your common peroneal nerve, your superficial peroneal nerve, and your deep peroneal nerve. And these can happen from any external compression, such as ski boots or trauma, repetitive micro trauma to the area. So think of those and try to remember that peripheral nerve pattern that I have here on the right side. So the sural nerve, that's going to be over your fifth metatarsal on that lateral aspect of the foot, things like that. Your superficial peroneal nerve is going to be primarily on that dorsum of the foot and ankle. Then also consider CRPS or complex regional pain syndrome. This is usually a chronic thing. Usually you think of this post-traumatic. It's not going to be implicated as much in someone like a runner, but still something to consider. And so again, let's just think of where some of our major compartments are in the nerves that are involved. So with our anterior compartment, that's going to be the deep peroneal nerve. And that starts to come off pretty high up near the proximal fibula. Then we have our lateral compartment, which is going to be our superficial peroneal nerve. So again, that's going to get a large portion of our anterior foot and tibia. And so that's going to be one of the ones that are more commonly implicated in a uh, peripheral nerve entrapment. And then, of course, like we talked, our superficial posterior compartment is going to be our sural nerve. Again, it's a pretty small amount of real estate that we're working with, but still something to consider for our sural nerve entrapment. And then we have our deep peroneal nerve entrapment in our our lateral, our anterior compartment, which is going to get that web space between the first and second toes. So if we have a patient who is having some foot drop, because they're having some foot drop and they're having some decreased sensation in that first and second web space, then you need to consider the anterior compartment being affected, and specifically a deep peroneal nerve entrapment. The next three slides, there's a lot going on, but I want to walk through them because I think they highlight a key learning point, which is, I think, more helpful clinically rather than specifically for the CAQ. But we just went over these four buckets of differential diagnosis. And I think one of the key things to remember is that there's a ton of overlap. And it is very hard to make the diagnosis of these different etiologies because there's a lot of overlap. They take significant amounts of testing. They're very involved testing. And so the diagnosis can remain very elusive for quite some time. So on these different graphs, you'll see at the top, like each column is a different diagnosis. So we have chronic exertional compartment syndrome, we have shin splints, we have tibial stress fracture, we have superficial peroneal nerve entrapment here. We have myofascial tears, which I think the authors meant like an acute like calf strain. That one I'm pretty much going to ignore. We have radiculopathy, and then we have popliteal artery entrapment syndrome. So the big buckets that we were just talking about. Now, each bar represents the percentage of patients diagnosed with these etiologies who had this symptom, essentially. So you can see pretty much every diagnosis has a pretty high proportion of exertional pain. That makes sense considering we're talking about, the diagnosis of exertional leg pain. But you can get some key bits of information. So for shin splints, they note that the pain is fairly diffuse compared to tibial stress fractures, which are very localized. So I think that's helpful to keep in mind that if you're evaluating someone on the bony side of things and they have a very specific point tenderness, that's more concerning for a true stress fracture or a stress injury rather than shin splints. As opposed to, so let's say, shin splints persists after stopping for hours to days. I think that's pretty interesting compared to CECS, which subsides after a few minutes to hours. All of them also have gradual onset during exercise. That's pretty common. So let's see, radiculopathy has pain at rest, whereas CECS does not by definition. So pretty interesting to kind of see where some of these differences lie. But again, I think my key takeaway from this slide is that there's a ton of overlap, at least in the symptoms. Oh, one other key thing I want to point out for tibial stress and bone stress, pain is worse with weight bearing, whereas shin splints does not have any pain with weight bearing. Same thing with CECS. So if you do see that on the history, that is like a little key thing. So they also provide the same type of graph for other, basically like the description of the type of pain. I think it's interesting most of them describe the pain as a dull aching pain. That's pretty common in all of these types of pains, except for radiating pain and shooting pain, which falls under radiculopathy. So that kind of fits, our typical history. But again, even something like numbness, altered sensation, paresthesias, which we would definitely think could be radiculopathy, obviously falls under the same thing as a superficial peroneal nerve entrapment and also falls under CECS. So you can't necessarily use these things to differentiate between the diagnosis. Some other things, some interesting things. So skin coolness is more, I think, indicative of popliteal artery entrapment syndrome. It's not found in any of the other diagnoses, so that may be a little bit helpful. Things like intermittent claudication is more popliteal artery. That makes sense. But cramps can be both popliteal artery and CAQs. So there's a few things that may be helpful to delineate, but a lot of this, there's a ton of overlap. And then finally, the last of these graphs, which just looks at physical exam findings. And so there are some interesting things. So a positive tuning fork sign is, again, much more indicative of a bone stress injury rather than just shin splints. Altered sensation and hyposensitivity is found in all of the neurogenic things. So radiculopathy, superficial peroneal nerve, but it's also found in CECS. So not super helpful. Diffuse tenderness is, again, this is on physical exam that there's more diffuse tenderness, is more in line with shin splints, whereas the local tenderness, again, falls in more under that bone stress injury. And let's see, other things. Positional loss of pulses, which we talked about, having the leg in full extension, having the patient plantar flex, and do they lose a pulse? That falls under popliteal artery entrapment syndrome. So that is actually a little bit helpful. So there are, again, some small, subtle differences, but I think in actuality, when we're talking to patients, it's hard to get some of this history. It's hard to get some of these physical exam findings. And so there's a ton of overlap. And so, what does that mean? So how do we rectify that? How can we actually then try to make the diagnosis? Again, I think it's helpful to remember that it is hard to make this diagnosis. And this is my general, just very basic algorithm to start with, which is we get an x-ray because we're sports medicine doctors and we're going to get an x-ray. It's really going to be helpful. Maybe occasionally you'll see, that they have an obvious tibial stress fracture. Maybe there's some other bony abnormality, some bony tumor, something like that that might explain it. But in general, it's not going to be super helpful. I next then recommend an MRI. And I usually start with just a plain MRI tib-fib without contrast. And I'm primarily doing it to look for bony abnormalities. I just tend to find in my practice, and I think some of the studies after reviewing for this lecture bear out that our bony bucket is still going to be the most common one. And so to me, I want to rule out that there's bone stress injury before I do any other invasive testing. So I'm going to start with an MRI to evaluate for that bone stress injury or shin splints. If that is negative and I have any further clinical suspicion, that's where it diverges. That's where I'm trying to see, okay, does this sound more like CECS? Does this sound like true exertional compartment syndrome? And if that's the case, then I'm going to shunt them and I'm going to do compartment testing. If it seems like it's more popliteal artery entrapment syndrome, maybe it's more claudication, maybe I felt that there was a decreased pulse when I examined them, or they noticed that their skin color is changing, then I may go down the route of popliteal artery entrapment syndrome, and I'm going to be ordering ABIs, ultrasound, and from there may have to do the MRI angiography. So that's kind of my just basic algorithm is we're going to rule out bony stuff first because that's just the most common, especially in our runners. And then we'll go through one of the other testing based on all those things that we talked about, the physical exam, history, things like that. So let's talk in more depth about CECS and testing for compartment syndrome. Oops. And let's talk the Pedowitz criteria, because these are the numbers that you have to remember for the CAQ. You just have to remember, you're probably going to get a question on them. And we'll talk about, are they fantastic or not? But these are the numbers to keep in mind. So pre-exercise compartment testing pressure greater than or equal to 15 is diagnostic. Again, in the Pedowitz criteria CAQ world. Number 2, a 1 minute post-exercise pressure greater than 30 millimeters of mercury. And then at 5 minutes post-exercise, greater or equal than 20 millimeters of mercury. So I'm going to, go through those again because this is going to be on the CAQ. You have to remember these questions. Pre-exercise greater than 15, 1 minute greater than 30, 5 minutes greater than 20. But let's see. So that's the CAQ. But let's actually talk about the real world. And so this paper was kind of a review of all of the different studies which have published like exercise compartment testing pressures. And so there's a lot of things, a lot of going on this graph as well. What I'll call your attention to is the dark gray are patients presumed to have CECs. And the light gray are patients who are control patients, normal patients. So what you'll see that at rest, you actually do have a pretty significant amount of CECs patients who have fairly high resting pressures, anywhere from about 15 all the way up to 50, which is extraordinarily high. But in general, you'll see that patients with CECs have a pretty high resting pressure. And you'll see that a lot of them are greater than that like 15 number that we need to keep in mind. But let's look at that 1 minute post-exercise. So this is kind of where, these are the actual numbers from the Pedowitz study itself, which you can see that all these bar graphs, patients with CECs were above 30. They range anywhere from the low 30s all the way up to 50. But the thing to keep in mind is that they did have pretty elevated intracompartmental pressures. And when you look at the patients who did not, the normal patients, their pressure was a little bit higher than baseline, but it still wasn't higher than 30. Basically, the highest control patient got up to 27, and we'll come back to that number. But still, in general, that adage of the Pedowitz criteria greater than 30 certainly bears out in all of these studies. And when you look at that 5 minute number as well, it's pretty similar as well. All the patients, the dark gray were the CECs patients, and their numbers were pretty high as well. The control patients were all pretty low, like 15, less than 15. So that's where kind of we get those classical numbers. Now it's not perfect, but that's where we get it. Now this review kind of put everything together, and this is, quote from that review. They do note that the current intracompartmental pressure testing criteria for CECs is likely unreliable, and we'll see that in the real world example with Liam. But an emphasis should remain on good history, and I would also add physical exam. However, clinicians should consider measurements taken at that 1 minute after exercise. That basically the authors are saying is a pretty good number, because when they look at the studies, all the controls had 27.5 millimeters or less. So that magic number of greater than 30, the authors of this review paper suggest is highly suggestive of CECs. And so you should take that seriously for that 1 minute post-exercise. So I kind of went through that tangent to show like the real world is different, but this is where we get these numbers. And there's a reason why these numbers on the CAQ are there. And so that's why I remember 15, 30, and 20. So let's go back to our patient. Our patient Liam looks at you when you talk about, so we've gone through the algorithm, we've gotten an MRI of his legs. The MRI looks negative, there's no bone stress injury. He's still been training for his baby marathon, and he says it's getting worse. He's increased his mileage, and he's still having pain, and his legs are just really swelling up every time he goes to exercise. And so we're now talking about doing this compartmental pressure testing, and we're going to walk through how to do it. But he looks at you, pretty concerned because you're saying, I'm going to have to what? I'm going to have to put a giant needle in my leg. So he's pretty concerned. So let's talk about how to do that. First of all, I do want to note, I do not have any financial disclosures. I do not have any endorsement. I'm going to have images of a certain company's device here on the screen. But really what we are doing is I'm focusing on how to use the generic term is a solid state transducer catheter. So again, I do not have any financial ties to said company, but they are one of that I use them in clinic, and so that's why I have pictures of them. But again, what I'm describing is for a generic solid state transducer catheter. So these are the 4 steps to kind of just preparing to take compartment pressure, because I do this in the emergency department when we have to test for acute compartment acute compartment syndrome, but it's not something that we do very often in sports medicine clinic, family medicine clinic, things like that. So I think it's important just to like go over the actual physical act of like how do we measure a compartment pressure. So the first thing we're going to do is assemble everything. We're going to fill the needle of the solid state transducer catheter. We're going to zero it out. We're going to enter in the skin, and then we're going to pulse the catheter. So I'll show you what that looks like. So these are all the supplies that I need to test someone's compartment pressures. You need the actual device that usually comes with a pressure monitor. It usually comes with a sterile syringe with some saline and a needle with the catheter. You may also want some sterile gloves, some iodine or chloropreps, and maybe some lidocaine to anesthetize the skin as well. The first thing you're going to do with whatever kit that you're using is you're going to attach your saline to the device. And you're going to assemble everything. So you're going to attach the saline to the device, and you're going to take whatever needle comes with the kit and apply that as well until you have everything lined up. And then you're going to fill the chamber stem. And so what this does, when you fill everything with saline, essentially what you're doing is you're creating a continuous column of fluid. You basically want fluid extending all the way from the muscle where the patient's at, all the way through the needle, back through that chamber pressure, so that the device can measure that pressure. So when everything is continuous, you're measuring the pressure even though the needle is outside or the device is outside of the skin. There's that continuous pressure column. So that's how we actually measure the pressure without leaving the device in there. So you're going to basically prime everything by making sure saline comes all the way through the needle. Then you're going to take the needle and you're going to put it into the device. And again, there are different ways, but this is the Stryker way to do it. You're going to put the device in, you're going to click in. And so that is essentially where the device is measuring the pressure is through that little chamber stem. Once you have that, it's going to click everything on and you're going to turn on the device. And that's everything to prep everything. Then I'm going to get the patient ready. And I like to use ultrasound. We're primary care sports medicine docs. I like to use ultrasound to see exactly, which compartment I'm in. Obviously, we can do this with palpation. You can palpate the tibia and go just lateral to that, and that will get you your anterior compartment. But there's just something about ultrasound, just confirming everything, and especially the lateral compartment, just to make sure where we're at. So I'll find that lateral border of the tibia. I'll come just off of that and palpate that anterior compartment. And I'm looking for that tibialis anterior extensor digitorum. And I'm just going to mark that skin. And I'm oftentimes, if we're testing everything, I'm also going to anesthetize just the skin. I try not to get too much fluid into the actual subcutaneous tissue in case it messes up the measurements, but we'll definitely at least do the skin. So we'll find our anterior compartment, and then I'll take the probe and shift it a little bit laterally. And one easy way to find the lateral compartment is to palpate the fibular head and then go about 3 or 4 centimeters distal to that. And then you have your ultrasound probe. This is really the only compartment that I think, or this one and then the deep posterior, I think are the most important ones to actually use ultrasound to confirm. Again, you can do it by landmark base, but I think it's really helpful to actually see like the true lateral compartment. Like you can see the fascial layers surrounding this compartment. And so I'll mark that area and then I'll also anesthetize the skin. Then I come to the medial border of that tibia to find our posterior compartments. And at this point, I'll usually have the patient externally rotate their leg. And from here, that is where I find our 2 remaining compartments. I'll find the lateral gastroc and soleus for our superficial posterior, and then I'll try to find our deep posterior. And when I use ultrasound this way, I can see how deep that deep compartment is. Now, when you put the needle in, you should be able to feel some pops through the fascial layers, but it's much more helpful if you just take your ultrasound and you measure down and you're like, oh, my deep posterior compartment is 3 centimeters deep. I know that I need to insert the needle 3 centimeters deep. And so the reason why I do this is I can then measure both compartments with one needle stick. So I will enter in the needle, basically 1 centimeter to get that superficial compartment. I'll take that measurement and then I'll insert the needle even further all the way down into the deep posterior to about, the 3 centimeter mark, if that's how much I measure it, how deep it is. and then I'll take that pressure there. So it saves the patient an additional stick and allows us to still get those measurements. So I've now marked out all all three of the locations that I'm going to insert the needle for all four of my compartments. Then you actually need to get the needle measurement. So let's say we're doing this for the pre-exercise measurements. So we're doing this in a nice and controlled manner. Once you have that solid state transducer ready to go, you hold it just above the skin at the same angle that you're going to enter in the skin. And then you're going to zero out the device. And that is basically, you have to do it at the same angle because of pressure waves and things like that. So you're basically going to try to enter the skin at a 90-degree angle with that pressure device zeroed out at the same angle. So then you're going to puncture through the skin. Once you get to where you think the compartment is, usually for the anterior lateral or superficial posterior, it's really only going to be, depending on how much subcutaneous fat, you're only going to go in 2-3 centimeters max. Once you're in the skin, you're then going to gently depress the syringe, and you're going to pulse, is what I described. You're just going to pulse a little bit of fluid into that space. So what that does is that displaces any soft tissue that may have gotten taken up into the needle, and then that creates your continuous column of fluid. So now you've gotten rid of any other tissue. Now you have just fluid inside the muscle space coming all the way back up into the column, and then that provides you your pressure measurement. Typically, when you do that pulse, there's a sharp increase in the pressure. So it may jump up to, we'll just say 30, and then it starts to tick down 30, 29, 29, 28, 27, 27, 27, 27, and it stays level for a few seconds. And that level number, once it's kind of come down, that's what you're looking for. So that is the whole process of how you do it. It's pretty simple once you've done it a couple of times before, as long as you remember a few key things of zeroing the device in the correct, 90-degree orientation that you're about to enter the skin, and then getting a feel for what the device looks like after you pulse the fluid and measuring that pressure as it comes down. So you're going to measure all of those pressures pre-exercise in a nice controlled manner. You're going to get used to doing it. So now you will have tested, if you do four compartments, 3 sites on each leg, well, now you've done like 8 different compartment pressures just in the pre-exercise. So you'll get really good at this. But now we need to do the actual exercise part. So this is where it's logistically interesting depending on your clinic setup. I'm going to show an example with our patient Liam of what it's like. But what I do in the clinic is we have a treadmill in our PT office, which is down the hall from our our actual clinic rooms. And so what I try to do to facilitate time is, we get the patient exercising, we get them on the treadmill, we get them running until they start to have pain. And then when they're done, we get them off the treadmill. And they literally run through the hallway. They run through the rest of the PT office. They run through the hallway all the way, going past the orthopedic surgeon rooms, past the fluoro suite, all the way back into their room. And then they jump on the table, get their legs ready. And we, usually myself and some assistants or a fellow, we get ready to start taking their pressures. And so it's really kind of like an all hands on deck to try and get as many pressures as you can within those time frames, right? Because we just talked about, we have our pre-exercise, our 1 minute and our 5 minute, pressures. But in reality, how can you actually get multiple compartments done all at 1 minute? And the actual reality is you can't. So this is, we get Liam to crawl all the way down the hall, we get him in, and then we start taking his pressures. And this is from a real life patient that I actually had a couple months ago. It was a patient where we did both legs, and this is what a real life example looks like. So we have the compartment that we're measuring, we have our pre-exercise measurement, we have our post-exercise, and then we try to get the amount of time that we started. So basically, as soon as the patient stops running and they get on the table, we start a clock. And then one of our assistants, either an MA or another fellow or a resident, starts recording all the times while we are trying to measure those compartments. And so you can see The first one that we get to is still 48 seconds after the patient stopped running. So by the time they literally physically, stop running, lay down onto the stretcher, we basically rip off any band-aids that we have from the pre-exercise test, and then we get the needle in, and then we zero it out and we pulse it, and it still takes 48 seconds. So in this patient, in their left anterior compartment, which is the one we are most concerned about, you can see they actually started off at 24. So technically by the Pedowitz criteria, that was positive pre-exercise. But most importantly, post-exercise, it came up to 35. So it meets that 30 threshold. And so I thought that was pretty consistent. It was, consistently high pre-exercise, and also post-exercise was pretty consistent. And importantly, clinically, when I was performing this, his compartments felt like legitimately firm. They felt very firm. So I felt very confident in my measurement that, oh, that's definitely positive. So then we tried the left lateral, because he was also having some symptoms in the lateral compartment. And pre-exercise was also positive. Now, post-exercise, it actually went down. So I wasn't sure what to do with that. And it highlights how we talk about these numbers, but we're still ultimately relying upon a device. And so there's the CAQ, answer of if they give you a definitive pressure, that's what you go with. You don't question it. But in reality, these are devices that may not be 100% calibrated, and there's quirks in how you get measurements and things like that. But it was positive before and not quite positive afterwards. But, so that's why I wrote a question mark on there. So we went from the left leg, then we went to the right anterior and lateral, because I was more concerned about those and decided we could push these posterior compartments on the left to the back. So after a minute 20, we got around to doing the right anterior, which pre-exercise was again positive at 20, but post-exercise was also positive at 30. And again, clinically, his leg felt very firm. When we checked the lateral compartment, same thing. It was positive pre-exercise, positive post-exercise. So I felt pretty confident that his right anterior and lateral compartments were positive. But then when we look at some of the other compartments, his superficial posterior looked fine pre-exercise. Post-exercise was still pretty high at 2 minutes and 26 seconds. Now, clinically, it felt soft. Um, but I don't know. Is that positive? It's kind of hard to tell with some of those measurements. When we look at the deep posterior, though, they were both negative. Well, sorry, it was high early on, which is why I wrote a question mark, because I didn't think I had any clinical concern, but then post-exercise, it was negative. So I don't know that I would necessarily call that positive, just because of that variation. So I think this highlights that you have to still even take into account the clinical aspect when you're taking these pressures. I had high clinical suspicion for anterior and lateral, and the pressures lined up nicely, and he felt very firm on the right side. Pretty much the same thing for the left side, but even so, I was concerned about the lateral compartment, and post-exercise, it was normal. But I felt clinically for both of these, we could say, okay, he was positive in the anterior and lateral compartments for both legs. Unlikely to be superficial, or sorry, unlikely to be posterior, but maybe, because we have some spurious values with 36 in that deep posterior. So hard to tell again, and that highlights the difference between a CAQ question and what we see in real life. So let's talk about treatment options for CECs. So there's a ton of options. None of them are great, which is why I only have like a few slides on it. It primarily comes down to physical therapy. That's probably the best option is doing PT, specifically with gait retraining, and also doing some activity modification. There's some thought that you may be able to change some footwear that might be helpful, maybe offloading may be helpful. But for CECs, it's going to be largely PT gait retraining. Let's talk about some more advanced options though. So let's say you do physical therapy, that's not helpful. What are some of the more advanced options between surgery and injections? So surgical fasciotomy is kind of the classic end stage for CECs and actually has pretty good pain reduction compared to conservative management. However, there's no difference in return to activity rates. So you have to talk with your athletes like, yeah, you may have a little bit better pain, but you may or may not actually return to your sport, just by doing the fasciotomy. And there are complications with a major fasciotomy surgery, hematoma, nerve injuries, scar issues. And interestingly, 10% of patients who have a fasciotomy need a repeat fasciotomy, which is pretty high. The flip side, though, is a pretty significant amount of patients would be willing to have their fasciotomies again, meaning they thought that they were pretty effective. So a little bit of, mixed data. I think this on the whole shows that fasciotomy is probably helpful in a lot of patients, but in a pretty significant chunk of patients, they either need a repeat fasciotomy or it doesn't really matter because they don't even return to their activity. Now, we'll also talk briefly about Botox. Um, we've had some patients in our health system who have gotten Botox for CECs. Now, it's ultimately so far in the literature just only case reports and case series, and they're primarily from military studies. The studies show that there's anywhere between 9 to 36 months of symptom relief, so it seems fairly helpful. And the injection protocol that's most often used is 25 units in the lateral compartment and 50 units in the anterior compartment. And with the Botox, you're trying to find the sweet spot of paralyzing just enough muscle um, while also treating the symptoms. So Botox may be, something helpful going forward, but still a little bit more experimental right now. All right, that is our rapid fire review of everything. With our last couple minutes, let's do a few CAQ questions, and these are all from prior ITEs. So a 20-year-old female runner presents to your clinic for evaluation of left lower leg pain. It's cramping, occurs after 1.5 miles of running. Exam is unremarkable, and you decide to test her for exertional compartment syndrome. That anterior compartment at rest is normal at 7. 1 minute post-exercise is 25. 5 minutes is post-exercise is 22. The posterior compartment at rest 12, 1 minute post 27, and 5 minutes post 18. Which phase of the gait cycle is most likely to be affected by the patient's condition? So think of which compartment is ultimately diagnostic by the numbers, and then which phase of the gait is being affected. Ooh, okay. Yeah, this is a tough question. This is um, one reason why I took this one. So answers look like they were split between A and D, so mid stance and initial swing. So I brought this question out. We didn't talk about, the gait cycle, but that's one reason why the CAQ is tough because you have to know, different things and answer the question. So this is the gait cycle. So the correct answer is D, the initial swing. So let's go back. So I went over, an example of how the real world is messy. The numbers don't always align, but on the CAQ they do. So for these, the posterior compartments, all these normals are number, right? At rest, that's less than 15. 1 minute is less than 30, and 5 minutes is less than 20. So the posterior compartment is normal for this question. The anterior compartment at rest is normal. 1 minute post-exercise is normal, but 5 minutes post-exercise is greater than that 20. So the authors wanted you to know that, okay, the anterior compartment was being affected. Then you have to go to the next order, a level of thinking, which is to know, okay, what does the anterior compartment do in the running cycle? And the anterior compartment is again that primarily that tibialis anterior, which provides dorsiflexion. So that is primarily going to be the initial swing. So on this little diagram, the initial swing, if we're looking at that left leg, as that left leg is swinging through, you have to activate that anterior compartment to dorsiflex the ankle. Otherwise, you're going to get foot drop. So lots of different steps to that question. Looking at, anterior basically compartment being affected, causing inhibition of that dorsiflexion. All right, question number 2. 45-year-old male presents with complaints of numbness in his right foot and tripping over his right toes. He got back from a ski trip 3 days ago. He rented some equipment, noted that his boots felt too small. He points to the web space between his great toe and second toe as the area of numbness. He has a bruise on his distal right shin, tenderness in that area as well. He also has some slightly limited dorsiflexion, and he has a weak dorsiflexion as well. Which nerve was affected by his ski boot? All right, good. Most people got the correct answer of B, which is that deep peroneal or fibular nerve. So we'll just quickly go over our compartments again. So it's basically describing that anterior compartment again, that tibialis anterior, extensor digitorum longus were knocked out. That anterior compartment's on the anterior side of the leg. You can imagine with really tight ski boots, we're compressing that area, compressing that deep peroneal nerve, which led to inhibition of those muscles. And that's how we got that patient. And then our final CAQ question. Popliteal artery entrapment syndrome most commonly involves compression of the popliteal artery with which structure? Excellent. 100% correct. Nicely done, everyone. I went over that pretty extensively, but everything, all the anatomical variations are primarily in relation to the gastroc, that medial gastroc, with the exception of the type 4, which is the popliteus, but everything else involves the gastroc. So good job. And that is it. So let's give a hand to Liam. We diagnosed him with chronic exertional compartment syndrome. We actually got him into physical therapy to really work on some gait retraining and some PT. And he comes back to the office a couple months later and lets you know that he's been doing well with the gait retraining. He's so happy that you made the diagnosis, and he can now get back to his exercise and moving around without any discomfort. So, our key takeaways. We went over our 4 buckets of exertional leg pain. We have our bony, our vascular, our muscular, and neural. We kind of focused on stress fractures and shin splints on the bony. We focus on popliteal artery entrapment for our vascular. We focus on CECS for muscular and peripheral nerve entrapment for our neural diagnosis. Our algorithm is not elegant, but it's what we have. We start with X-ray. After that, we're probably going to get an MRI without contrast to look at the bony structures. And then, if that's still negative, based on history, based on some of that exam, we'll consider either a vascular path or compartment testing. For compartment testing, we know that our Pedowitz criteria, we talked about real life. It's a lot harder to piece together all the different pressures, but for the CAQ, you got to remember 15, 30, and 20. If we make the diagnosis of CECS, our treatment options is PT, gait retraining, fasciotomy, and then Botox, with the asterisk being that it's a little bit more experimental. All right.
Landon, that was excellent, or Dr. Mueller. Um, there are a couple questions in the
Yes.
chat. One of which was on the workup of popliteal artery entrapment. So before advancing to MRI angiography, we do pre and post exertional Dopplers, both arterial and venous. What are your thoughts of doing that?
Yes. So that is actually like that is what I think the guidelines say. And maybe I wasn't fully clear with that. So yes, you do ABIs. You can also do the pre and post exertional Dopplers. And it's essentially doing the ABIs, but with exertion. So you're basically just getting that measurement. And essentially, if you get one ABI pre-exercise. You have them do the exercise, and then you get the post ABI. And I believe if it goes down, you may need to correct me. I think if it goes down a pretty significant amount, I think I read like 30 or 40%, then that's also considered diagnostic.
Excellent.
I think you may still want to eventually get the MRI to look and see if it's one of the anatomical variants. Um, but then you at least know, okay, if the anatomical variant looks okay on the MRI, then we at least have a functional diagnosis with the ultrasound.
Um, the other question that is that I actually had similar was, what is the return to activity rate after
Mhm.
Botox injections for the chronic exertional compartment syndrome?
I do not know off the top of my head. That's actually a great question. So because I was reviewing my like data on these studies, there's truly only like 4 or 5 published studies on this. There's a couple of like 3 case reports and then 1 case series. And the big case series, if I remember correctly, was a Scandinavian country. Like it was a Scandinavian military. And so they were experimenting with Botox. I want to say that it was a pretty decent return to activity, with return to activity defined in those circumstances as returning to military activity. Um, but I don't know 100% off the top of my head. It's a good question.
interesting to me, and I don't know how much strength or disability would happen just from the Botox. Like obviously you're
Mhm.
not completely paralyzing the muscle.
Right. Yeah, and I think that's I think they found that that 50 units in the anterior compartment was the sweet spot for most patients. I think they experimented and started doing like 100 or maybe a little bit more than that, and they found that they were causing foot drop. And I think they found that 50 was that sweet spot of not causing foot drop, but also helping with symptoms.
And then just one other question is,
Mhm.
do you find that you surgeons want to repeat the pressures if they're kind of inconclusive, even though clinically you think that's what it is, or what is your experience when you refer?
In my experience, the surgeons always defer to us. And
Yeah,
maybe that might just be our health system, but basically like the surgeons aren't testing pressures.
yeah,
And so they're basically relying upon us. And if we do the pressures and we say like, yeah, I think this is pretty positive, then they'll take our word for it. With that said, I have had a couple of patients where the pressures were a little equivocal, and we ultimately decided like, hey, before you do surgery or before we do Botox, let's just do PT. And if things aren't getting better, then we can retest and essentially try it again. And then if those retest numbers once again seem positive, then I think we would feel more comfortable like sending you towards that surgery route if you need it.
yeah. I find that it's frustrating with the physical therapy. You definitely have to know what they're doing with with your athlete and
Hmm.
kind of have close follow up because it just all adds to the length of time that it takes to kind of get to the resolution.
Yeah.
And getting the patient to buy in completely is hard because having them
Hmm.
to decrease their activity, retrain can be really hard when they're like, well, can't I just do the surgery?
Yes.
And that's actually the follow-up question was what's the harm in a fasciotomy for marginal pressures? Like what's the negative of doing
Hmm.
a fasciotomy?
Hmm. Yeah, I mean, it's there. In reality, the chance of a scar, nerve issue, hematoma is pretty low, especially in our healthy athletes, but it's not zero.
Right.
And I've certainly treated some of my collegiate athletes who had fasciotomies when they were in high school, and then I go back through the records, and it wasn't like fully diagnosed, like they didn't have pressures, they just went and got the fasciotomy, and now they're still having pain. And so then we have to go back and think, okay, is it one of these other buckets? Or is it still CECS and you need a repeat fasciotomy, right? 10% of them need repeat fasciotomy. So it's interesting to kind of reconcile that data of like there's can be real harm and there can be, a repeat need for fasciotomy, and yet still three-fourths of people were happy with it. Um, so I think like anything, it's a tool in our toolbox for the right patient.
Well, this was a really excellent review. It's, I take care of a lot of runners and I see a lot of exertional pain. And so I was excited that we were doing this topic and you just really did a great job with overview.
Appreciate
I
it.
think it could help all levels of people, not just our newest doctors, but the advanced ones as well. So thank you so much.
Yes. Thank you, everyone.